Hello, my name's Chris Payten. I'm a speech pathologist at the Gold Coast University Hospital in Queensland and a doctoral student at the University of Sydney. And I'd like to share my research on the speech and language pathology, first contact assessment for voice disorders. I'd like to begin by acknowledging my co-collaborators on this project. A comprehensive assessment of voice needs to be multidimensional to encapsulate the wide-reaching effects of a voice disorder, from the physical impairment to the psychosocial impact. We as voice assessment specialists will interpret a combination of symptoms obtained through self-report tools and case history, and signs from our perceptual scales, laryngeal palpation, and visualizing the larynx to make judgments on the nature of vocal quality, pitch, and loudness. We also use objective measures to quantify our interpretation from the subjective measures. However, there is little evidence and no internationally agreed assessment criteria that exists for which combination of assessments can be used to classify one voice disorder from another. Direct visualization of the larynx is generally accepted as an initial diagnostic assessment because it's the most likely to rule out structural or pathological causes. However, laryngoscopy is a brief assessment of structure and function of the larynx, and the value is dependent on the ability of the clinician to interpret the examination findings. A typical pathway in the public health system for patients with symptoms of dysphonia is referral from GP to ENT for initial assessment and medical diagnosis, including direct laryngoscopy or stroboscopy. However, when no organic structural or neurogenic cause is identified, many patients are referred to a speech pathologist for continued assessment and management. For example, around 40% of people referred for voice assessment have no organic cause, and voice therapy is the recommended treatment. Recommended assessment is therefore multidimensional, including both ENT and speech and language pathology as a minimum, using multidimensional assessments to encapsulate the complexity of these disorders. However, a significant number of patients wait longer than clinically recommended for their ENT outpatient appointment in Australia, and this delays their access to speech pathology treatment pathways. The Speech and Language Pathology First Contact Clinic is an expanded scope model where patients can be triaged quickly, with the SLP conducting routine clinical assessments in a parallel clinic to ENT. This follows a case discussion with ENT and a joint review of instrumental assessments before a confirmed diagnosis and treatment plan is agreed. This model can ensure ENT surgeons use their expertise on more complex cases and surgical interventions, and patients receive multidimensional voice assessments much earlier. Similar models have been reported in the literature, suggesting shorter waiting times and improved access to speech pathology. There are many drivers for changing the way we deliver care. According to the Australian Productivity Commission, simply expanding the current workforce is not enough. We need to adopt new ways of working to make care more efficient and coordinated, shifting from volume-based care to value-based care with a focus on improved patient outcomes and lower healthcare costs. AHPs expanding their scope with the knowledge and skills they have, or extending scope, can develop more efficient models of care. Expanded scope allied health practitioner models have been reported in the literature over the last 15 years as an effective way of reducing waiting times for assessment and identifying referrals suitable for allied health practitioner and non-surgical interventions. Our prospective cohort study on the speech and language pathology first contact voice assessment reports on service measures, including waiting times for assessment and the outcomes after initial assessment. We saw low priority category 2 and 3 patients who met predetermined inclusion criteria after triage by the ENT surgeons in a speech pathology first contact clinic running parallel to ENT, as I previously described. Our triage system is a two-phase system. All referrals are triaged by the surgical advanced registrar in training and then those deemed appropriate for the speech and language pathology first contact clinic were screened by the advanced speech and language pathologist for inclusion. We aim to capture all patients who will likely benefit from primary speech and language pathology intervention for this clinic. A total of 219 patients were seen in the speech and language pathology first contact clinic in the first 12 months. Our comparison group were patients seen by ENT in the 24 months prior to implementation of the pathway, matched with the study group for age, symptoms at the time of referral, and triage category. There were no significant differences between the two groups. To measure the true wait time difference pre and post implementation, we separated those seen by the speech pathologist into two groups. Those referred before commencement, thus spending time on both the ENT and speech pathology waitlists, and those referred after commencement directly into the speech pathology waitlist. A linear regression analysis demonstrated patients in the ENT group waited significantly longer than those in the two speech and language pathology first contact groups, respectively, and wait times reduced by an average of 277 days for those patients referred directly into the SLP-FC. Our discharge outcomes were recorded for patients seen only in the speech and language pathology first contact clinics. 81% of patients did not require further ENT assessment or management after case discussion. They received an average of 2 occasions of service by the speech pathologist, and 46% were referred to the voice treatment service. Of the 29 patients who returned to ENT, this was mostly for management of the unrelated symptoms not mentioned in the GP referral. This included rhinosinusitis and hearing loss. However, 11 of those patients were recategorized for urgent ENT management for reasons including organic pathology in the larynx. They were subsequently seen by ENT after an average of 15 days, whereas they may otherwise have stayed on the waiting list for many, many months as a low category patient. There were no recorded adverse events for any of the patients seen in the speech and language pathology first contact clinic. So in conclusion, this study demonstrates the speech and language pathology first contact clinic provides a timely one-stop, multidimensional assessment for eligible patients, and it supports faster access to the most relevant treatment pathway. However, it's a model that's not readily available and needs further research. Given the current emphasis from the best practice guidelines on the need for a laryngoscopy at the first contact assessment appointment, and of course scope of practice for speech and language pathologists in the diagnosis of laryngeal pathology, there are obvious limitations to this model as a standalone assessment without the reliance on ENT colleagues to verify assessment findings. Whereas laryngoscopy and direct visualization of the larynx by a medically trained ENT surgeon is a critical element for the diagnostic purposes, delays to accessing this assessment are common and may impede timely assessment and treatment in the long run. Further research is required to understand how the speech and language pathology-led model can support the MDT process of voice diagnostics with better utilization of services. My PhD is to investigate the speech-language pathology first contact assessment model for voice disorders to provide evidence for what diagnostic information and clinical assessments best identify patients with a dysphonia deemed suitable for primary voice therapy. I then want to establish if patients can be reliably triaged to the first contact speech pathology voice assessment model and receive the same treatment recommendation by a speech pathologist and by ENT. I hope to demonstrate this model is a safe, reliable, and cost-effective way of assessing patients while waiting to see ENT for diagnosis. My future studies include a global web-based survey of practice of ENTs and speech and language pathologists to gain their insights into what clinical data is routinely used to inform the voice diagnosis, and then an experimental study presenting recorded clinical data to groups of speech and language pathologists and ENTs to measure the level of agreement of diagnostic impressions and recommended treatments. Thank you very much for your time. I'm happy to take any questions via email.